Shall we go to the next topic?
Yes, sir. Good evening, sir, and good evening, everyone. My topic for discussion today is a 47-year-old chronic smoker suffering from TAO posted for lumbar sympathectomy. TAO is thromboangiitis obliterans. It is a non-atherosclerotic segmental inflammatory occlusive disease of small and medium-sized vessels, primarily in the distal extremities. It is strongly associated with smoking and it is predominant in males. The clinical features of this are a triad of claudication, rest pain, and ulceration and gangrene. The role of lumbar sympathectomy in TAO patients. Lumbar sympathectomy is a surgical or chemical disruption of the lumbar sympathetic chain aimed at producing vasodilation in the lower limbs by eliminating the sympathetic mediated vasoconstriction. The types of lumbar sympathectomy are surgical and chemical lumbar sympathectomy. Surgical lumbar sympathectomy may be done under either open or laparoscopic approach. Where the lumbar sympathetic ganglia of L2, L3, L4 are excised. When chemical lumbar sympathectomy is performed via image-guided injection of the neurolytic agents like alcohol or phenol. The position is done usually under a lateral or prone position depending on the surgical approach. The approaches may be retroperitoneal or transperitoneal, and it may be done on unilateral or bilateral based on the symptom distribution. The targeted ganglia are L2, L3, and L4. Pre-op I will ask for history of vascular symptoms like claudication, rest pain, ulceration, and gangrene, and any history of color or temperature changes in the limb, and any history of paresthesia in the limb. Smoking history, I will ask for duration of smoking and the number of pack years and the duration of the last smoke. I'll inquire about other comorbidities like COPD, CAD, diabetes, hypertension, any history of previous stroke or DVT, and I'll ask for any other drug histories like vasodilators, antiplatelets, or analgesics. Any previous history of previous revascularization or any previous amputation done was to be noted. Now, pre-op preparation, general examination, vitals, I'll look for heart rate, pulse rate, respiratory rate, NIBP, and ankle brachial pressure index, I'll look for it. And vascular examination to be done with distal pulses to be felt, and capillary refill and ulceration over the extremity should be noted, and the BMI of the patient can be noted. In CVS, I'll ask for any palpitation, dyspnea, chest pain, or any failure symptoms. In RS, I look for any added sounds like bees and bilateral air entry since he's a smoker. And CNS, I look for any neurological deficit, any paresthesia or pulselessness, and airway assessment to be done, spine assessment, and IV access assessment to be done. Then investigations, I'll ask for CBC to look for polycythemia and infections. I look for random blood sugar, HbA1c, RFT, electrolytes, LFT, coagulation profiles, chest x-ray to see for COPD changes, ECG and echo to rule out coronary artery disease or silent MI, and ABG and PFTs if COPD is present, and Doppler ultrasound and angiography to look for the vessels and collaterals, and the duplex imaging of the involved limb can be done, and RA factor and antiphospholipid antibodies and ANA profile can be done for to rule out other vasculitis. Pre-op optimization, smoking cessation preferably over 6 to 8 weeks, and chest physiotherapy, any bronchodilators and incentive spirometry should be given, and treat the infections and ulcers, and adequate hydration and nutrition to be maintained. Peri-op use of anticoagulants and antiplatelets to be discussed with the surgeon, and the aspirin can be continued. Silestazole, which is usually used, has to be stopped for 48 hours before the neuraxial procedures. Anesthetic goals, intra-op anesthetic goals are optimize perfusion of the ischemic limb, avoid vasoconstriction, which is due to pain, hypothermia, hypoxia, stress, or hypovolemia, maintain hemodynamic stability, manage smoking-related pulmonary issues, and to provide good post-op analgesia, to prevent DVT, infections, and wound complications, to tailor techniques to avoid the peripheral vasoconstriction. So the choice of anesthesia is regional anesthesia is preferred, which improves vasodilation and good analgesia. GA is considered if a regional anesthesia is contraindicated, or if the patient refuses, or if there is any laparoscopic approach for the sympathectomy, then GA can be used. Avoid vasoconstrictors, avoid hypothermia or hypovolemia. The position can be done in lateral or prone position. The regional techniques involves the low dose spinal at the L2, L3 to L4 levels, and epidural is more titratable, and we can combine sedation with oxygen supplementation also. Monitoring, standard ASI monitoring to be done. Arterial line if there is severe CAD or any vascular disease. Temperature monitoring to be done on the limb, affected limb. Then fluids, ensure adequate preload, avoid fluid overload, and fluid should be warmed to avoid vasoconstriction. Avoid vasoconstrictors like phenylephrine. Post-op management, the pain control may be done with epidural analgesia with local anesthetics or opioids, paracetamol and NSAIDs if renal function is good. Monitoring of the limb perfusion to be done. Look for temperature, color and capillary refill, and vital signs and peripheral pulses to be felt. Look for urine output. Watch for hypotension post-regional block. For pulmonary care, deep breathing exercises and incentive spirometry can be given post-operatively, and chest physiotherapy and early ambulation can be done, started. DVT prophylaxis to be given, and smoking cessation support should be continued in the post-operative period also, and ulcer and wound care to be given. That's it, sir.
Very good. It's a very rare case scenario which we commonly don't see nowadays. So it's very frequently seen during our student days. The common things, common case scenarios, patients come for amputations of the gangrenous group. And why is smoking? It's like it's considered as a very important cause for this particular disease. What is the mechanism?
Smoking causes inflammation, and the endothelial disruption causes inflammation, which causes occlusion of the arteries, segmental occlusion.
That's one theory is it causes the sensitization of the endothelial lining of all the vessels. But in particular, the peripheral vessels are affected because the nicotine in the smoke, cigarette smoke especially, that is a hapten. What is a hapten?
Immunoglobulin with antigenic properties.
It's a small particle. Okay? By itself, it doesn't have any antigenic property. Okay, a small protein particle by itself, it will not have any antigenic property because of the low molecular weight, less than 1000 Daltons. But it can cause antibody formation, antigen antibody reaction. How? When it combines with a larger molecule. Okay? So the haptens always in our body are very low molecular weight. They always combine with a larger protein, then become antigenic to create an antigen antibody reaction. Can you tell me another example of this in anesthesia, where a hapten can become antigenic? In relation to a volatile anesthetic agent, that is a clue I can give you. Uthupriya, Birami, Mundaria,
Sir.
any other hapten which can which is by itself will not antigenic but can become antigenic by combining with a larger protein molecule, a bigger molecular weight. What is the mechanism of halogen hepatitis?
BCDF production.
That is how it produces. The immune-mediated halogen hepatitis is because of the hapten that is synthesized and then it joins with a larger molecule producing the same problem. Okay. Similar
Yes,
to
sir.
that, the nicotine can stimulate an antigen-antibody reaction by acting as a hapten which combines with a larger molecule and produces changes in the vascular endothelium. And as per the definition you said, it's very important. It's a non-atherosclerotic vascular disease. Okay? It is not a normal atherosclerotic. What is the other name for this disease?
This is
Burgess
Vegas
disease.
disease.
Burgess. Burgess disease. And is there any test to do before doing the lumbar sympathectomy, either by chemical means or by surgery? Is there any means to see whether the patient will be benefited by the surgery or not?
Capillary refill, sir.
Well, it will be definitely reduced because of the lesser flow. But my question is there any test to find out whether by doing this sympathectomy, whether there will be any benefit to the patient or not? How to find out? Because sometimes even after sympathectomy, patient may not have adequate blood flow and relief of symptoms. So is there any procedure as you do to find out what is differential spinal? Have you heard of the term differential spinal?
One block is sensory and another will get motor, sir.
What? Don't follow you. See, nowadays, every day you are giving spinal, isn't it?
Yes, sir.
Huh? What drug you use?
Bupivacaine, sir. 0.5.
You again what? Heavy,
Heavy
hyperbaric
point.
or isobaric?
Hyperbaric.
Heavy, sir.
Hyperbaric, okay? So when you use hyperbaric bupivacaine 0.5%, what is the level of sensory block? What is the level of motor block? What is the level of autonomic block? You all are equal or there
No,
is a
sir. The sensory level is
2 segments above the motor level.
motor level.
motor?
And the autonomic is
Autonomic is 2 segments above the sensory.
Yes,
Okay?
sir. Yes,
So
sir.
why does this happen? Why it is not all the 3 are not in the same level?
The
Nerve
order of
roots, sir.
fibers.
Hmm?
Nerve root fibers.
Now root fibers. The root fibers are there. All the root fibers are the same size. What will happen to the drug that you are injecting as point? Supposing you are giving a subarachnoid block at L3, L4 space. You are giving 2
will
ml
ascend.
of 0.5% bupropion. Okay?
Yes, sir.
What is the weight of the drug after you give the drug into the
Drug
CSF?
will ascend in this
The drug goes
subarachnoid
ascending up,
space,
isn't
sir.
it? Depending upon
Yes.
the position. If you keep the
Yes,
head
sir.
up tilt, it will stay low. If you keep a head down tilt, it will travel up because of the hyperbarism. Okay. As it travels high up, will it remain as 0.5% or will it get diluted with the CSF and become 0.4, 0.3, 0.2, 0.1 like that?
Get diluted with the
It will
CSF.
get diluted because it is mixing with a larger pool of CVS and CSF, isn't it?
Yes,
So
sir.
when the concentration of the drug falls, will it be able to block the thicker fibers the same way it does at the lower level where it is as soon as it is infused, it is a 0.5 heavy concentration?
No, sir.
No, isn't it? So the dilution causes the difference in the blockade of the different fibers of different diameter. Okay, the smallest fibers get blocked with a very low concentration. Even when the drug gets diluted up to say less than 0.1% also, autonomic fibers are getting blocked because of their small size. And sensory fibers being little larger than autonomic fibers, they get blocked by a little higher concentration. And motor fibers can be blocked only with the highest concentration available. Okay, so that is the reason why you have these different levels of blockade, like motor will be the lowest, sensory will be the next higher point, and autonomic will be the highest point of blockade. Okay. So if you choose a concentration which will selectively block only the autonomic fibers, what will happen to the patient? Say for example, to make you understand, you are giving 0.5% at L2, L3 or L3, L4 space. At the level of T4, T5, the concentration becomes 0.1, where autonomic fibers are alone blocked. No sensory or no motor fiber blockade will happen at T4 level. Okay? And you inject selectively 0.1% bupivacaine, which will not cause any motor blockade or sensory blockade and blocks only the autonomic fibers selectively. What will be the effect on the limb?
Temperature change.
Huh?
Temperature change.
You will have increase in the
Temperature.
because of vasodilatation and increase in the blood flow. So what you can do is you can measure the temperature of the foot or the ankle before administering a very dilute concentration of local anesthetic, and then inject the low concentration local anesthetic into the subarachnoid space. Wait for about 2 to 5 minutes and measure the skin temperature again. And if you find there is an increase of at least 1 degree centigrade in the skin temperature from the pre-block to the post-block, that patient will definitely get benefited by the
Sympathectomy.
lumbar sympathectomy. Okay, that is how we used to confirm the whether this surgery is going to be beneficial or not. Okay, this is called differential spinal testing, where you have to measure the skin temperature before block and after block and see whether there is an increase in temperature due to increased. Okay?
Yes.
So that is a point that can be asked. Is of course because we are all not exposed to this sort of cases immediately, not common. You remember this sometimes they may ask you. Another
Yes.
important advancement in the treatment, apart from earlier compulsorily we were doing the sympathetic, whether chemical or surgical. Is there a modern treatment for improving the new vessel formation and increasing the blood flow in the affected limb?
Prostaglandin prostaglandin injections and
Prostaglandin
analogs.
therapy which can cause angiogenesis or new vessel formation, which is used even in chronic ulcers, diabetic wounds which are not healing, by creating more, injecting a basal. If I tell you, the answer will be very evident. How are the new vessels or tissues are formed, especially vascular
Angiogenesis.
angiogenesis? How does it happen? From which cells they are all produced?
Stem cells.
Stem cells.
Fantastic. Stem cells. So you can do stem cell therapy also.
Yes.
So how is the stem cell therapy done? Supposing they want to do stem cell therapy in this patient. Have you ever seen a stem cell therapy being done?
In bone marrow.
Where do they do it? How do they do that stem cell therapy? They aspirate the bone marrow from the pelvic bones, especially the iliac crest. Okay? They put a large bone.
I have seen for knee replacement, sir, in Metas.
Yeah, and you can aspirate the stem cells bone marrow and then centrifuge that and inject it into the location where you want new vessel formation to take place. So that is a very simple procedure. In leukemia and other cases, they do it what is called the bone marrow transplant. It is given intravenously of injecting it into the location where you want to grow. One of the important treatment for acute myeloid leukemia, where you can do the so-called bone marrow transplantation. Nothing but the aspiration of bone marrow. It can be done after irradiation and injecting the bone marrow aspirate into the patient. It's called autogenic injection. Or you can do it as an allogenic procedure from a donor. You can choose a compatible donor and then aspirate this bone marrow from the donor and inject it intravenously. Okay, so that is all. So one of the accepted treatment. I just share my screen with you.